As an emergency physician, I've seen firsthand what happens when people lose themselves in their work. That's why I built a coaching practice grounded in real data, not guesswork. When we work together, you'll start with a DISC assessment, which will generate a 40-page deep dive into your behavioral strengths, your motivators, and the workplace triggers that cost you the most. Then we bring in objective biometric data. We can use any number of wearable devices, including the Oura Ring, to understand how your sleep and recovery directly shape your capacity for joy and performance. This isn't a one-size-fits-all program. Every coaching engagement is customized to you because the work of following your heartline looks different for everyone. If you're a healthcare professional ready to reconnect with why you started, visit the link in the show notes or head over to AndreaAustinMD.com.
Welcome to Heartline, Change-Making in Healthcare. I'm your host, Dr. Andrea Austin, a board-certified emergency physician, physician development coach, and educator. After years on the front lines, I've learned that real change in healthcare starts within. Each episode invites you to explore the inner work that unlocks clarity and bold leadership, because healing systems through change-making begins with following our heartlines. I am so excited today to have Dr. Sarah Smith on the show. She truly is a change maker, and we're going to be talking about change making, about sustainability, about what to do when the system keeps asking you to do more, which was my day today. So, Sarah, welcome. How are you?
I'm good. Thank you so much for having me.
And tell our audience where you're calling from today.
Yeah, I'm far north Queensland, Australia. We moved back here about a year and a half ago after spending 12 years in Canada. We went to Canada to see something different for a year and stayed a little longer than anticipated. Loved it. I learned some of that North American style of medicine and the differences there, but eventually came back.
Amazing. The first question we always start with is when or what was the experience that you realized that you were a change maker in medicine?
Okay, this is a great question. So, for about 15 years, the first 15 years of my postgraduate attending practice, I could not figure out how to get home with the work of the day done. So, I was working many hours after the clinic ended, many hours after the last patient went home, despite having small children at home, working evenings, weekends, just not able to figure it out. And we actually had a team come to our clinic who were change makers. That was part of what they would call themselves, and or improvement facilitators. And they asked us to do things like, please mark how much fruit and vegetables your patients are eating and how much exercise they're doing, if they're a smoker or not. It's just an extra button you have to press. And it was the straw that broke me at that moment. It was, please stop asking me to do more. Don't you already know how much I do? I cannot give of myself any more than this. And so I was so mad at them asking me to implement change. I had no capacity for change. And it made me so frustrated. In the conversations I was having with the lead there, Dr. Sue Peters, so she's not a doctor, but Sue Peters, who is the implementation manager person that the Alberta Medical Association had sent out to our clinic to help us understand how change can happen. And as part of this rollout, they were saying, doctors go home with the work of the day done. The work of the day is done. I'm like, oh, well, if you're going to start adding that to the equation, I'm all in. But when I started looking at their resources, oh, they're going to help me. There was nothing there specifically for me. They were helping the team do things differently and starting to see how they could take things off our plate. Great. But there was nothing specifically about how I interact with patients, how I interact with the team, how my day goes, who's asking me to do things, who's interrupting me, none of that. And so I was still mad at the system for asking me to do more. At the same time, I learned about coaching and the internal experience of our day, that frustration, anger, dread, miserableness. I started learning some of the mental tools to help me understand I'm having a story about work, which is hurting me, is creating suffering, and it's not allowing me to show up differently. I'm just having this same experience on repeat year after year. And so I also heard this little nugget that said, impossible things are possible. And I'm like, but you don't understand. This administrative
Mhm.
burden, this is more than impossible. This is literally impossible. You can't help me. You're not a doctor. You can't see what I do in my day. But there was no one else in the world helping doctors get home with the work done. There was nobody out there in the world to give me the strategies, the skill set to do this. So I followed along this general life coach's advice on changing my inner experience of my day and then truly stepping into every available opportunity to change how I was showing up in my day to make my day sustainable. So it had to start with me. I had no capacity for anyone else. I was looking personally as a very selfish experience to literally get home with the work done. I wanted my life back. So the change for me happened with me, for me. And then we ended up with bucket loads of time, and my colleagues were suffering, and I wanted to help them too. So that's where I became interested in helping others too.
So I can just imagine the physician listening to this saying, well, I want that too, Dr. Smith. How is it even possible? Like, how do I even get started? So let's start with the very real scenario. Yeah, I'm emergency medicine. Some days I walk in a 12-hour shift, I might be asked to see 40 patients.
Mhm.
Are you telling me there's a way that I could get home on time?
Okay. So emergency department is one of the little pieces of my life. So I was an emergency department physician rurally as part of my career. So I get it. And I've looked after emergency department physicians too, who have got 6 hours of their life back because the physicians who come into my circle are typically there hours after the last shift, getting all of that completion of tasks done so that they can have a clean slate when they go home. Sometimes they will take that work home with them, and occasionally we'll see backlogs happening for emergency physicians, but typically they're more press in and just get it done now so they can go home with their slate clean. And I like to say this is an us problem, not a you problem. If you think about the physicians in your department who are staying there hours after the last shift, hours after, they're exhausted. They've seen 40 patients in this 12-hour shift and they're there for 6 hours after their last shift change. How eager are they to keep coming back day after day after day? We're going to lose them.
Not
That's not
here.
sustainable.
Amazing.
It's an us problem, not a you problem at this point. I am interested in why you are still there after your shift. And so we need to start stepping back and saying, wait, the documentation is important too. It's significantly burdensome. So these electronic medical records are not designed for years of getting notes done. So when we started back in our early careers, we wrote it on paper. It was fast. It was scratchy. It was terrible, but it was done. Now we use our mouse. Our click burden is heavy. The whole thing is really cumbersome to switch between different screens to figure out who this person is and what are the important parts and where is that test I ordered and how do I know that the nurse is asking me to do this or that. Cumbersome. And so we start having conversations. It starts with us saying, I want to go home earlier, but it's an us, the team. We want to get out of here on time. We recognize that the documentation is important. So, one, we understand that as teams work together well, they have better disaster mitigation. So, think about the experiences we have in airline crashes. If the team has worked previously together well, even when they're exhausted, they do better. So, starting that shift with a conversation. Who's here with me today? How is everybody? Is there anything I need to know about you as we go through the shift today that's important for you? The quick share, the quick team coming together will help us work better today. Part of that conversation, you could even say, I check when there's a notification that a patient needs Tylenol. You don't need to come tell me. If you have an ECG that's not urgent, this is where I will be coming to do documentation. Leave it there. I will see it. having these conversations about how to interrupt you, it's crowning, coding, bleeding, seizing, come get me. Otherwise, I will get you, or I will see it here. Here's how to interact with me. That can already offset some of the interruptions of the emergency department.
I love that phrase. If you're crowning, coding, bleeding, or seizing, come interrupt me. Oh my gosh. I'm so stealing that one. That is great.
Yeah, or puppies or fresh coffee. And I mean, the consultant's on the phone for you. We usually have devices in our pocket now. That shouldn't have to be a come fine to me. Just ring me on my phone. Like literally, that's what it's in my pocket for. Number 2, how do we look after you too? So we want work done up to where you're at right now. And this is without apology because you've got 40 patients this shift. As you walk into the room, you're gathering information, get it into that file right now. It is not the end of the story. It's the beginning of the story, but we record it in real time. That could be typing, dictation, whatever you like. Just make it happen.
Ambient dictation. So I don't know if we're going to get into it. I've started to do some AI assisted dictation. And as I'm learning it, I'm loving it.
And sometimes it's helpful. And sometimes it's 2 out of 5 stars because it makes things up. So you really have to be checking it in real time too, because if you're coming back to saying,
Yes, I agree with that.
the left or right, half the time the AI is getting it wrong. But if you're using an AI, learning how to use it well. So you could be saying your exam findings out loud, but then check it in real time. We don't want a new work list at the end of the shift. That's not cool. We want to get it done in real time. And so we just pause that chart note there, put our orders in. We're coming back later to look at the orders, to give the patient information, to have our new diagnostic reasoning, our new assessment and plan. And we just update it each time we see them. So work is now complete behind you because that is allowing your working memory, which is very big as a doctor or a clinician, to not be crowded with all these 40 patients that you're going to put in there today. There'll be some times that you're pulled out to go do something serious and you can't document in real time when you're in the middle of being the crisis doctor for a moment. But once it's done, take that opportunity to take a deep breath, exhale, do some of those mini micro relaxation exercises while you're on the phone. You can do them. The square breathing can be done while you're waiting for a phone call to go through. Get the note done. First opportunity. Just dump it out quickly in real time. It takes much less time than doing it at the end.
Yeah, I love how your system really is, it's promoting embodiment. It's promoting teamwork and caring for the people around you. So you're really advocating for a huddle at the beginning of shifts. And as somebody who's simulation based, I love huddles. So that's really great. And I wonder how often when you're working with physicians and coaching them on this topic, for me, kind of the biggest thing that I had to get over to get my charts done faster was to get over perfectionism. I was very used to being a resident and having somebody go back and being like, well, you missed this on your differential. You could have said this better. And I've developed in my own head the charts that this one's pretty high risk. There's a pretty good chance somebody else might review this chart. And then there's the straightforward ankle sprain that's incredibly low risk that hopefully I have great templates for anyway. But like, if that chart's a B and not an A plus, I'm okay with that.
C minus, honestly, because here's the thing. You want to grade yourself against the Andrea who has an hour to do that chart. You don't have an hour to do that chart. We're now in crisis chart mode. Now you need to look at it as Sarah who hasn't had a pee for an hour and hasn't had any water and food for 3 hours and is busting and has to get this chart done because we know there's going to be something rolling in the door in 5 seconds and there's still a waiting room of people waiting for me. Then grade that chart and say, is there enough here to know informational continuity of what happened when they came in that time? So I had an example. An emergency physician was talking to me last week. She said she put the wealth criteria number in, but she felt bad because she hadn't gone into that section of the chart where the actual questionnaire is to tick all the boxes to tell why she gave it a 2. Oh, you wrote the number. You showed the device that you used, the tool you used to get the number, but you didn't go in and find the questionnaire to tick the boxes to demonstrate come on.
I imagine a lot of some of the healing and some of the work that has to be done is people have been traumatized by their training. They've
Mhm.
been berated. I can think back to my residency, and there was this one attending on, I wouldn't even say what service, insert whatever service you want to put in. And she was like Jekyll and Hyde. And one day she just went off about how the progress note was not done with enough attention to detail. And it's interesting because she really was passing on her trauma. She's
Mm,
like, do you know that I could get called into court and have to testify about this chart?
mm,
And the way you documented it, I'm not going to be able to remember. I think about hundreds, if not thousands, of stories that have
mm,
been told to us. You really have to shed.
mm.
Yeah. And I guess the question I've had to tell myself is like, do I want to do this job for 5 more years or 10 more years? Like the way I was doing it earlier in my career, I could probably only do it for 5, not 20.
Well, the department was different 5 years ago, 10 years ago, 15 years ago. It was different. When we hear the old boys tell us about how it was in their day and they'd had the waiting room empty by the time the next shift came in, it's changed. The scene has changed. One, the electronic medical record is 3 times longer than it was when they were working. Two,
Yeah.
the volume coming through, we can never hand over an empty waiting room anymore. That's just not the reality of how the emergency departments across the world are right now. They are stacked to full and you can't get people out and you've got people continuing to come in and we remain the Department of Available Medicine. So we have everything. So we hold ourselves potentially up against the slate of something that we've seen in our past, which is not the lived experience anymore. This is part of the things. The trauma of who are you thinking is looking at your notes? So I had the wonderful example of one of my colleagues telling me, just remember the newspaper sitting on your shoulder. That is not a good thing to think if you're trying to do your charting.
Right.
Also, who are you envisaging? The one I was envisaging that was holding me back from getting these charts done was somebody that I don't respect, but had been a bully and had been a very scary person as a resident. And when I realized I was holding my notes accountable to what he might think, I'm like, "Hun, I see you were there and goodbye." Right? That was very
Yeah.
liberating. We also are traumatized by the humans having human physiology. So when our patients do something unexpected, as human bodies do, and bad outcomes happen, our documentation is what we think is going to be helpful. It didn't create the outcome. The human body is a fragile thing that can go and be unwell and have bad outcomes despite everything we've done. So
Right.
sometimes we're also trying really hard in the moment to do our very best, knowing and forgetting that humans do and have bad outcomes. And then we have that horrible experience in our own bodies of something bad happened to one of my patients. And having that, we're emergency physicians, you've got you never intended to do harm. And then we learn as emergency physicians, as physicians in general, we can take what happened and we can put it through our, okay, if that happened again tomorrow, would I do it the same way or have I learned something from this experience? But the compassion needs to be there first. The ability to say, I showed up to do my best and always do, and I never show up to do harm. From that lens, I look at what happened and I might reflect with myself or with my colleagues or with my team to say, what's the structure we normally use? Is that what we would continue doing? Are we going to add anything in based on what just happened?
Yeah.
Sometimes our documentation is really attached to the potential harm that we've had to ourselves in medicine as well, from attendings, from patient. outcomes, all of it.
Before we get into today's episode, I want to share something that I think a lot of you need to hear about. Heart of Medicine 2026 is an international gathering of compassionate leaders in medicine. Doctors, nurses, allied health clinicians, coaches, healthcare leaders, all coming together July 29 through 31 at Voyagers Ayers Rock Resort in Central Australia. And yes, it's in Uluru, the spiritual heart of Australia. Because this event is intentional about where it places you, not just what it teaches you. You'll learn from world-class faculty about heart-centered care, compassionate leadership, and what it actually looks like to build a longer, more fulfilling career in medicine. You'll leave with the skills, community, and honestly, your spirit a little bit more intact. This is not a typical CME box check. This is the kind of gathering that reminds you medicine is still worth fighting for. I'll be there, and I'd love to see you there. Registration is limited because the resort is remote and intimate. So don't sit on this one. Link is in the show notes.
Yeah. So some of the take homes I'm getting is, letting go of some of those prior traumas, being compassionate, and it's okay to have some boundaries. What I find a lot of times when somebody interrupts me is it's like the game of hot potato. They have a piece of information that they don't want to hold on to anymore. And the faster they can give it to me, then they can go do their other thing that they're doing. But if I had 5 more seconds to finish my chart, then my chart's done and I don't have to go back and try to remember, where I was. And so again, you have to teach people how you want to be treated. And that phrase that you used at the beginning of if you're not coding, crashing, crowning, seizing, I think that's really helpful. You think you can also frame it with nurses and techs of this is also a patient safety thing because I might be entering in an order or I am trying to remember a key piece of history that they shared with me. And so by all means, if it's truly emergent, you can always interrupt me. But if you could hold on just a few seconds, I can usually finish my thought and then I'm going to be a lot more attentive to you. I think the tip I want from you is for the physician that's had no boundaries, because I deal with a lot of coaching clients like this. They've had no boundaries at work. And then I'm trying to help them have some boundaries. It's so hard because they've been the pushover. So now they're changing the way they want to show up at work. How do you do that?
So again, it could come back to that huddle at the beginning. It could happen in real time. But if they're going to hand over to you something about a patient and you don't have that patient chart open, that's dangerous. Think about your working memory. It's full of patients you have on the go right now. And all the things you're thinking about for the waiting room and all the things you're thinking about in regards to what could happen right now and all the formulations that you're doing in your head about the patients you've already got going. And you might be managing learners and then they come and say, Mr. Jones, blah, blah, blah. If you're not in that chart, that just goes in and out. Now they've hot potatoed to you, but you haven't actually put it in your working memory. So in the department, if a nurse was to come up to me and say, I'll be like, 1 minute, I'll get their chart open. So then I have to finish completing of the task that I'm doing right now so I can actually literally leave this chart, go into that chart. Now, what did you need? And I would put it in right now and then it's done. She knows it's done. She doesn't have to remind me. I don't have to remember it. And away we go. Consider it. Absolutely. It might get whooshed away in the wind, walk off on somebody's shoe. Do not, that's such dangerous practice. We need to be thinking about, we are all here to help our patients successfully. If you just give me that, it's going to get forgotten. I need that patient chart open so I can enter it for you now. Right.
Yeah, I love that because we shortcut so much. Oh, the patient in bed 8. Actually, I don't know. I've seen so many patients. I do need a second to make sure we're talking about the right person. And we're always supposed to be using 2 identifiers, right? So Mr. Jones, blah, blah. Yeah. I want to shift gears a little bit. So we've been talking, about the individual. If you ever advise or if you got to advise systems, what could a chief medical officer, hospital leaders do to start to really make a difference for the frontline clinicians?
Yeah, if we're using the emergency department as an example, as we consider this an us problem, not a you problem, you saying 6 hours hurts you, but it actually hurts the department because we're at risk of losing a doctor for that behavior.
Right.
So empowering us to understand that documentation is important, that's keeping people here late. Now what? What would it look like to allow the shift to be different so that maybe there's doctors coming on earlier in the shift, and when they arrived, their job is to say, for the next hour, I will hold your patients and you can do the documentation. Go and sit in that purple chair or in that back office, and you've got an hour. Go get some of that off your chest so that we can be closer to done at time. As an idea, or actually just asking, what is it that's preventing you getting home on time? And of course, it's volume, but there's also interruption. How are we talking as a facility? Where are we putting those interruptions? What are we seeing about the steps of this shift and the workflow of this shift and how many staff we have on and what do we need? So as they start to ask, what do you need? And they're genuine about their ability to say, let's see if we can make that happen. Then the front line feels supported. That's a wonderful question for an employer to ask. What do you need to be successful
What do
today?
you need? What do you need to be successful? And I would point people to two resources. One, Stanford's done awesome work on this. So the physician, they've actually, I think, changed the name to the occupational work fulfillment model. And so the three tenets of that is a culture of well-being or workplace efficiency. And then the last one is personal factors. Personal factors, sure. If you don't take care of yourself, you never get any sleep, and, all you eat is buns, then maybe you won't feel great when you go to work. There are some things in our control, but a bigger picture is like the culture of wellness. Like, do we actually care as an institution that our people are happy and healthy? And then that last piece is the organizational commitment to workplace efficiency. So, I'd like to make a movement that, if you're going to add a checkbox, you have to take away two in
Yes.
the EMR. Like, we don't get to add anything else. There is no adding. If you think something needs to be added, what are you taking away? Because there is no more give. We bootstrapped and tried to fix. And then the second thing I would say is for people to look at the AMAs, get rid of stupid stuff.
Mhm.
That's gross. Get rid of stupid stuff. I love it. And they have a lot of great toolkits for people to get started. Anything else you want to add? I gave a couple resources, but other things that the system can do.
So even having somebody follow a physician or a clinician, follow them for a few hours to see how they're doing things and saying, did you know if you did this and this, that would be quicker? Or did you notice this and this? You could have those types of helpful, even just EMR optimization pieces can make a huge difference how your workflow goes. Having computers on wheels or computers in rooms is important. And having them available so that you can actually take the thing into the room and get the work done in the room, even putting the orders in, even if you're going to come out and just dump and dictate after, being able to put orders in real time. So that is a more protected space can be helpful.
Yeah.
You don't have any of those, or the nurses have them, or I'm like, figure this out. You need this. This is a tool that you need to be successful.
Right. Badging in, badging out. So you have to do 6 different clicky
Yep.
clackies. Yeah. And again, you hit these organizational barriers of, because you're not a hospital employee, we can't do that. It's not a can't, it's a won't. And I think this is where that leadership component goes to. And I think, I can speak for myself. I've been in the learned helplessness space, and it's a really dark, sad place to be. But, recognizing Cherie Johnson always says, physicians have so much power. Literally, if you don't go to work, imagine if the physicians didn't show up for a full day in your hospital, what would happen? And once you realize that, you are really important. I mean, you have worth. We're both coaches. You have worth whether you practice medicine or not. But you have an incredible, important role. That healthcare system should really be listening to you. And you have to do it smart. You have to build coalitions and all of those things. But I think once you've done your personal healing, the listeners of this podcast, like, you can be the change makers, and you can work for improvements. And you can also migrate and choose to spend time in spaces that are responsive to you. I want to ask you a question because you've worked in Canada and you've worked in Australia, and I'm guessing you work with physicians from around the world. And a common story, maybe a trope at this point, is, if I just moved to Australia, all the problems I have here in the US would go away, and I would be this happy physician if I just moved to insert your country, Canada, Ireland. It's because the US has this horrible system with insurance. We don't have nationalized healthcare. So all I need to do is move. What do you think about that? What do you say to clients that say that that's the plan?
All right, I've got a couple of perspectives. I'm going to start with my personal perspective. So in Australia, when I left Australia, I was working evenings and weekends to try and figure out the work of the day. I had asked my clinic at the time, I was working in general practice, can I have somebody to help me get some of these complex care plans done? Because I don't have the time, but I've got a whole lot that can be done, knowing that it would grow the income of the business. And the answer was no, you have to figure that out on your own. So I just accepted that at the time. That was the answer. So that was the answer. I hopped across the pond to Canada, and I was still working general practice. I was also then added back in the emergency department and hospitalist care and long-term care and palliative care. So I was busy, and I would see up to 40 patients a day in clinic, but the problems followed me. So the inability to get home after the last patient in the evenings and the weekends followed me across the pond in a totally different healthcare system with different issues. So in Australia, it can be private billing for patients seeing the general practitioner and the specialist. The hospital is completely free through the public system or your private system where you might pay a copay, but overall it's less than $1,000 for everything you need while you're in hospital. So totally different than the US. In Canada, to see a doctor in general practice and the hospital system is free. We cannot charge patients for that. But what does that create? Longer wait time. So you might be waiting 2 years for your patient to see a psychiatrist, and that encounter will be free, but they're only going to get to see them once. So you as a general practitioner are going to be doing all of the complex psychiatry care for that patient, even though there are psychiatrists, they're not available to you. There's not enough in the system. MRI might be up to 2-year wait. So there's a lot of things different in the systems, and I'm still there hours after the last patient. I'm still working in the evenings. I'm still working on the weekends. And then nothing changed. My EMR, my staff, patients I was seeing. And yet, with some skills, with some change, I was getting home after the last patient with everything done. So
Yeah.
it's just the healthcare system. There is a skill set available to us. There is a different way of thinking and working within the systems that we are in already that can help us figure it out. And that's what I love, is that we can create sustainability where people are right now. And then, of course, that you've always got choice. You can go and decide to work anywhere you want. There's going to be issues in every system that you work in. Every system has limited capacity, a specific structure on how they see patients and how appointment books are booked in. Like, I have complete autonomy over how many patients I'll see in a day, what time I'll start, what time I end my day, how long my lunch break is in Australia and Canada within general practice and family medicine. I can literally set it up however I want. And yet I was still going home late. I was still working evenings and weekends if I hadn't figured out how I was going to interact with this system.
Yeah, I think that gives people so much to reflect on. And I see it a lot. I've had friends, physician friends that, like, all of my problems are related to this particular hospital, this healthcare system, this bad boss. And then lo and behold, they switch jobs. And a few months later, we're having a lot of the same conversations. And it just really goes to show like two things can be true at the same time. You could have had a not great working environment and a not great boss, and there could be some room for growth. And, that's where coaching becomes that accelerator. Sure, you might figure a lot of these things out over a 20-year career, but man, could you have shortened the learning curve, which vis-a-vis is often the suffering curve, right?
Yeah, I totally understand that. I've had physicians within the last few years of their working career come into my circle and they'll hear me talking about some strategies and things. And I've had a number reflect and say, I didn't believe her. I thought she was talking nonsense, but I thought I'll just follow along some of the ideas that she has. And lo and behold, I've got time to go swimming again in the morning. I'm having less evening work to do now. Oh my gosh, why didn't I figure this out years ago? Like, it's just that the human brain does what it does day in, day out. And absolutely, the system is broken. The system is not designed for you. The electronic record is not designed for you. It's all too much. There's too many clicks. You're asked too much. I agree on all of the above, right? We are being asked to do too much. So now it's up to us to figure out, how do we interact with the system that keeps asking us to do more? Because if we don't start interacting with it differently, it will keep asking for more and asking for more until we cannot anymore. And it is unsustainable already, let alone the continuing ask. And there are environments where we do have truly toxic, harmful pieces happening. And that's important to recognize. So we're not trying to dismiss any of those pieces, but also there can be this unlocking of you within the systems that you work. And that can be so liberating for you.
Yeah, yeah, I've spoken to other coaches about this, and I think the conclusion a lot of us have come to is if you're suffering as a clinician, get coaching and then reassess if you want to stay in that job. Optimize yourself as much as you can. So that way, if you decide at the end of it that maybe this isn't the right place for me, or maybe I want to truly do go down to part-time or whatever, you're making it from an empowered place that, I've really looked under the hood and optimized what I can and in coming at this decision in a much better place. So, I always tell fellow physician coaches, the work that you're doing is life changing and in many cases life sustaining, because we know that this chronic stress can lead to depression, anxiety, and suicidality. And we also know this chronic stress can increase our cardiovascular and who knows, all the other things that it might be doing to us. So I really think if you're feeling this, I talked about it in my book, this soul level, you're feeling like your heart sink or whatever those physical manifestations are, that is the time that you want to reach out for help, because there truly is a way to practice medicine and like what you do. You may not like every day, but it should not be a chronic slog. It should be sustainable. And I think that's maybe a good way to start wrapping up is, what does a sustainable career in healthcare mean for you?
Yeah, that's a great question. I like to ask people what their goal is. So for me, I wanted to be home with the work done. That was my sustainable. If I could do that, it would be sustainable. But that wasn't the truth, because I could have stayed there till midnight every night and got home with the work done. And that's not actually what I wanted. So actually, it's about, what do I want? It feels impossible, but what do I want? And I wanted this. I wanted to see the last patient, get that note done, maybe check it if there was anything specifically urgent that had come in since the last time I had checked, and go home. So I wanted to be home after the last patient. I want to be leaving the office 10 minutes after the last patient. That was my actual impossible goal. At the time, it felt completely impossible. But for me, that was what was going to become sustainable. And so that was goal I went after. Took me 18 months on my own and with a general coach just helping me with mental mindset to figure it out. But the thing is, if we don't quit and we are willing to show up to fail at this impossible task and keep going and doing things in a different way, we can achieve impossible things. So whatever it is that for you, you say, if I could do this, that would be sustainable, then go get it. But it's going to take changing how you do things. It's going to take learning potentially new ways of doing it, like how to disappoint people could be part of the things you have to learn. Like how to set boundaries could be part of the things you have to learn. How to do a chart note that I give myself a solid C- for might be part of the things you have to learn in the pursuit of what is it that creates sustainability for you in your environment right now. What would that look like? And sometimes you can't even imagine what it is to have that. But that ability to say, I want different, that means going and learning new things and doing things in a different way. But here's what I want. And just being clear about where that end is. And you might not get all the way there, but in the pursuit of doing things in a different way, it already starts to feel lighter or better because you start having some agency and advocacy for what you're looking for.
Yeah. I think a few things for people to think about is leaving on time's a wonderful goal. Other goals might be, I want to be able to do this job and still feel wholehearted, like I get to be tender and I get to care for my patients. I want to do this job and I still get to do this hobby I really care about. That's one of the most common things my coaching clients, one of the things I ask about now is, what do you like to do? Okay, when's the last time you did it? And frequently the answer is, the last time I did that thing was 3 months ago or 6 months ago. Or, I really like to be able to see my friend group at least once a month. Okay, when's the last time you saw them? 3 months ago or 6 months ago, because they know not to call or text me anymore because I'm usually not available. So you see this loss of hobbies, this loss of social support and social connections outside of work, and then this exhaustion. And then the last one I'll let people ponder is, I'd like to do this work without maladaptive coping mechanisms. And maladaptive coping mechanisms is, well, I know I have these 6 shifts ahead of me, but I'm going on this vacation and I'm going to buy something really expensive because I had those 6 shifts and I deserve it. I mean, that might be what you want to do, but if you're doing it just to get by, that's the only thing that gets me to go back to work. It might be time to see, what is that maladaptive thing? I can do this work if I go home and I binge watch Netflix and eat an entire box of cookies as I finish my charts. Okay, if that's, the way you want to live your life, but most people would probably say that's not actually how I want to live my life. If I want to binge watch Netflix, I'd rather do it without the EMR open.
That's right. Exactly. Yeah. Yeah.
Yeah. Well, this has been really delightful, Dr. Smith. I'm guessing, people are going to want to know how to connect with you. Charting is such a pain point. The EMR is so terrible. What socials are you active on? Where can they hear your podcast? And do you have any programs or things coming up soon?
Yeah, so I have a Charting Champions program, which is for physicians. It's a lifetime membership where we will really allow you to come in and tackle the weeds of your day with getting that sustainability of clinical day. So that you'll find that at chartingcoach.ca, and that's where you'll find how to access the programs that I run and things that are happening. I'm on Instagram, Charting Coach. You can find me there. And Sustainable Clinical Medicine is the podcast.
I love that. It's so easy. Charting Coach. I love that you got that name and branding. And then Sustainable Clinical Medicine. Yeah, it's so easy. And I love that word sustainability. So I really want the listeners, as you walk away from this podcast today, to let that be the key word that you think about. How do I create more sustainability in my clinical day, in my clinical life, in my life overall? And Know that myself and Sarah and many other of the guests that have been on this podcast are here for you. And if you need help creating that sustainable life, reach out. Anything else, Sarah?
I think that just take to heart that impossible things can be possible, but start with small, simple steps. Start just noticing what's happening for you in your day. That noticing can be so empowering. And then as you start to decide what it is that you want, go for it.
I love that. That is such great advice. So, yeah, getting back into your body, feel your feelings. It's okay. If it's not okay, it's not the end, is the other phrase. And know that there's a place for you inside medicine and there's a path. This has been a joy. I am very happy our paths crossed. And it's always great to see somebody from Australia. I always joke that you're coming to me from the future because it is Wednesday afternoon here. So when is it there?
It's Thursday morning here. Yeah, that's right.
That gets me every time. All right. Thank you, Sarah.
Bye.
Thanks for listening to Heartline, Changemaking in Healthcare. If you're ready to deepen your own inner work or want to bring these conversations into your organization, visit AndreaAustinMD.com. You'll find resources and ways to connect with me for coaching, speaking, or consulting. Don't forget to subscribe, leave a 5-star review, and share this episode with a friend or colleague. Until next time, keep following your Heartline. This podcast represents the views of the host and guests. It does not represent the views of any entity we work for or with. It is also for informational use only and does not replace any professional advice, including medical or psychological. If you are interested in unlocking your true potential, reach out to me. If you're an organization interested in supporting the well-being of your people, I'd love to connect on innovative solutions. Schedule a strategy session at AndreaAustinMD.com.